So thank you for all coming. You're troopers. This is the end of the day. So these are the hardcore people, I guess. So what is a neuropsychologist? Are you all familiar with what neuropsychologists are? Okay. So we're kind of a unique thing. My doctorate is in clinical psychology. I completed a 2-year fellowship in neuropsychology. And then we're cross-trained in psychology, neurology, and the neurosciences. And we're generally found at the major academic institutions and major hydrocephalus centers. We're primarily interested in brain behavior relationships. And so what we do is we assess for cognitive weakness and strength. We look at your emotions, your affect, depression and anxiety, your relationship with your disorder, acceptance of the hydrocephalus, and look at your general health, sleep, exercising, eating, socialization, activities of daily living, because all these make up you and your cognitive functioning and your quality of life, and that's really what we're ultimately interested in. So one of the big things we do is we listen. We want to hear from you about what's important to you. We want to help you strategize on how to have the best quality of life. What are your obstacles? Where do you want to be? What are your goals? Because in many ways, that drives the shape of our neuropsychological report, so we can answer your questions and also answer your physician questions. So what we do is we do diagnostic testing. We're looking for cognitive patterns that are similar or not similar to hydrocephalus. And testing can take anywhere from 3 to 6 hours. Actually, I think for normal pressure hydrocephalus, our battery is usually about 3 hours. So we're pretty quick in comparison to an all-day test, that is. 3 hours is not quick. Yes, ma'am?
What's the difference between the 3 and the 6 hours?
Actually, if we do a full-day testing, we usually do IQ testing. And we might look more at language. With normal pressure hydrocephalus, we're looking for specific things. And we're also doing a rule out to make sure that there's no other existing dementia ongoing, such as Alzheimer's or frontotemporal dementia, Lewy body disease. So we're really kind of, saying, is this Parkinson's or is this hydrocephalus? Kind of looking at all the options and getting the best diagnosis to give to your physician. So what we do is we do standardized testing. Testing is always administered in the same method, and we say the same thing so we can actually compare you to other people of your age and education. It gives us a sense of what's normal for you and what's normal for your age. And so this is a picture of someone actually receiving neuropsych testing. With the testing, we always go over what the benefits, the risks are to you. And so one of the things I always say to people is that, we're not going to stick your head in the scanner, no needles or anything like that. But what we are going to do is it's a little bit like going back to school. So we'll ask you questions. We'll have you make drawings. We'll tell you stories. Hopefully have you try to remember it. And then we kind of get an information about how your brain is working. I also tell people that sometimes the tests are hard. Nobody knows it 100%, so just relax and do your best. Some of the tests are easy and some of them are really boring, but the most important thing is to do your best. It's funny, in the last session we did, several people let me know that the tests were horrible, embarrassing, and yeah, they can be a little intrusive. When was the last time you all went back to school? It's been a while, and it's hard to sit for still that long. We try to take lots of breaks so people can, we can get a really good picture, not see, this is what you look like when you're tired, but this is what you look like when you're trying your cognitive best. So the kind of areas that we look for are language, visual spatial skills. Visual spatial skills are basically kind of looking at, where if you can remember where things in space, you're able to identify objects. In real life, oftentimes, it's where we put things, being able to find them. When we're driving, we use a lot of visual spatial skills for like parallel parking or regular parking. Can we pass somebody? Do we need to slow down, speed up? Those are all visual spatial skills. They're also involved in looking at facial expressions and body language. And perceptual skills, you know, basically, are you seeing, are you hearing, are you tasting, are you smelling? Oddly enough, one of the main signs of Alzheimer's is we lose our sense of smell. So that's always one of the questions I ask. Executive functioning, I've got a great slide coming up with that, so I'm not going to elaborate right now. But basically, it's our frontal system. This is the last part of the brain to be developed. Attention, concentration, memory, and fine and gross motor skills. We look, of course, with normal pressure hydrocephalus at how you're walking, because gait's are very much affected, and emotion and behaviors. Are you feeling depressed? Oftentimes when people are really depressed, it looks like a type of dementia. And we are able to tell that type of dementia looks very different than a normal pressure hydrocephalus. But the good news is that they're both treatable. So that's the exciting part. So executive frontal abilities, executive functioning abilities, are located primarily in the front part of the brain. And there's actually what we call a subcortical loop between this front part and the very middle part of the brain. That this is where our emotions are, and also our memories are gone and stored in the temporal lobe. So everything kind of comes through the middle part. And what the frontal lobes do is they're kind of, you know, direct memories. They consolidate them. You know, they help us pay attention to focus, which is actually the first step of being able to remember something. If you don't pay attention, you're not going to remember it. So if I asked you, for instance, how many tables are out in the lobby here, you probably didn't pay attention. It's not important to you. So how on earth could you remember it? It's a lot of things that we don't remember in life, is they just weren't important enough for us to pay attention to. And so this also helps us, you know, organize, anticipate, get started on things. Initiation is a big problem with normal pressure hydrocephalus. It's not depression. It's just that you just can't get going. And oftentimes priming people, you know, say, let's take a walk together, or, you know, encouraging, that oftentimes gets people going. And self-monitoring is your awareness of yourself, how good you're doing, how bad you're doing. You know, are you tired? Do you need a nap? And lastly, we talked about attention. So in the early 90s, we kind of looked at things like focal deficits in neuropsychology, but then we kind of moved more to neural networks, which, as you remember, looking at this one, we're looking at the frontal lobe talking to the middle part of the brain. Like, and if you want to retrieve a memory, you basically talk to the hippocampus, which goes and gets the memory, brings it out here, and then brings it forward so you can talk about it. Excuse me, sorry about that. So, and we generally look at patients from a whole view. So we're interested not only in your cognition, but how you're feeling, how you're sleeping, are you eating well, what your social skills look like, are you exercising, and what are your coping skills. We also look at resources. So what are your resources for support? Do you have family? Do you have extended family? Do you have like a faith-based support system? Anything that, you know, a network of friends that can give you support, because that helps, you know, build up your coping skills. So when you come in to see us, the first thing we do is we review all available historical information with you. We'll interview you and a family member. It always helps to have a family member along because they give us a different perspective. Sometimes, especially when we're depressed, we may not have very good awareness of how we're functioning. So it's very helpful to have someone say, you know, you do sometimes forget conversations. And we go, yeah, okay. And also, when we do the sleep study, or asking about sleep psych, they'll go like, you know what, you do snore. And often the person will say, I have no idea if I snore or not. So the next thing we do is we do the assessment. And so it's usually cognitive measures, behavioral measures, and then the emotional assessment. We then let the patient go home for the day. We'll score and interpret the data. And basically, the scoring and interpretation usually takes us about 2 hours. And then we write the report with the patient in mind, their family, the physicians, and any collaborative care providers. That would be like if you have an occupational therapist, a physical therapist, speech language therapist, cognitive therapist, and we often make referrals to them. And what we do is that report typically takes me for an all-day patient, will take me about 3 or 4 hours. For half day, I usually can do it in about 2 hours. So then we actually have, different neuropsychologists have different models. We like to have the patient come back and their family come back, and we give them feedback. And so we actually go over the report, we talk about the recommendations to make sure they understand them and they can follow through. Some neuropsychologists work on a consult basis, so they'll just send the report back to your physician. One of the nice things about where I work at the Brain and Spine Institute is I'll often go over and see the physician, go over the results with the physician before they see you, and so that we're all on the same thing. And I'll say, well, you know, I see this and this is happening, and I'm worried about this. And they'll go, great, then I'm going to do this and that. And so we kind of have a game plan, which is really great for the patient. I love collaborative models of care. It's really helpful. So, oops, I had that in there. Okay, so with memory, we have encoding, retrieval, and storage. So actually, it's kind of helpful to have this here, even though it's a mistake. So basically, when we learn new information, it's our frontal lobe that kind of gives things meaning and helps us understanding. Then they go down to the hippocampus, and then they get stored in the temporal lobe approximately. And then if we need to retrieve the information, that's, you know, when we say, well, tell me the story back that we read to you. And then, you know, your frontal lobe gets the information, then it comes back out. So one of the things I thought we could do is we could do a kind of like a practice neuropsych test. And I was going to bring pieces of paper, and I forgot, so I apologize. But this is what a neuropsych test looks like. So you'll notice I have 9 objects. And you know, if I brought pieces of paper, we could have written down, I'm going to take it away, but you could write down where you think the objects are that you could remember. So that would be the visual part. And the verbal part would be remembering what the objects were. Okay? So this is kind of what a neuropsych report looks like. And we will have given this to, again, thousands of people of your age and your education, and found out what's normal for your age and what's normal for your education. And sometimes it's broken down by gender. The other thing we can do is look and see what's normal for you in terms of remembering it. And then again, normal pressure hydrocephalus has a certain pattern, which is basically has difficulty retrieving and encoding information, but it recognizes information very well. So we know that. So go ahead and take a second, kind of look at this and try to remember as many as you can. Don't write it down yet, okay? Now go ahead and write down what you learned. Unfortunately, I don't have any paper, I apologize. But you can think, maybe count out loud. Oh, you have your cards, okay, very good. And you can also count, you know, remember like, okay, 1, 2, 3, 4. So this is a very common one. The tests I'm going to show you now are come off the internet, so kind of like the cat's out of the bag anyway. Usually we don't expose tests, but this one is looking at speed of processing and cognitive flexibility. And it's kind of a really interesting test because it also predicts whether people are going to have difficulty with driving. So basically with this, the person has to connect the number and alternate between the number and the letters. So they'll draw from 1 to A, to 2 to B, to 3 to C, to 4 to D, to 5 to E. And this is the practice one. And the other one, the test we actually give, goes all the way up to 24. Now, what this test looks at, one, is how fast you can do it. And the other thing is can you go back and forth between the two sets of information? And the reason why this actually kind of translates to driving skills is if you think about it, when we are driving, one, we oftentimes need to react really quickly to certain responses. So, you know, oftentimes with my older patients, they'll say, oh, but I have no problems driving, you know, I know how to drive very well. And it's true, because my grandmother, she could drive excellently. The only problem is she went all over the curbs, she went over people's lawns, but she still knew the act of driving. She knew how to drive, the procedure. We don't lose that. We don't forget like how to ride a bicycle. We don't forget how to walk, that sort of thing. But what we do lose is the part in the frontal part of the brain that says anticipate. So you see someone coming up and they're driving over on the side of your lane, so you need to slow down. What do I need to do? Or when the crazy, and that's another thing I always tell my elderly patients, I say, everybody has dumb drivers out there. They're going to do something that they're not supposed to do, and our job is to predict that when it's going to happen and make quick decisions on how to handle it. So the ball runs down the road. What do? Do you slam on the brakes? Do you go a little faster? Do you look for the little kid chasing the ball? Those are the things that we're concerned with driving. Those are the things that when we're older, and especially in Alzheimer's patients, they don't do too well. And sometimes we see this with neural pressure hydrocephalus. But again, as you know, with neural pressure hydrocephalus, we can make it better by putting in a shunt, and it's called actually one of the few reversible dementias. So that's the good news. So this is another test that is of executive functioning. This is a Stroop test. I think a lot of people know this one again. So you'll notice we have the word blue, and it is written in the green ink. So what this test does is if we were just to read the words, blue, red, yellow, orange, green, blue, purple, red, I can read it pretty fast. But if I say, well, tell me the color of ink, I have to inhibit my reading the word and tell you the color of ink. So it would be green, pink, I guess that's kind of an orange, red, yellow, red. That looks like a purple. Maybe that's a blue. Green. So there you go. But you see, it takes me a little bit longer to process that than just to read the words. And we're timing that, and again, looking at the difference between the two. So that looks at inhibition. So attention, what we're looking at is 3 different types. There's the passive working memory. So if I said every good boy does good, then you repeat that back, and that's just passive working memory. So just remembering what someone tells you. The average adult, all the way up through 70, usually can remember 7 units of information. Forward and back, and backwards is more your active working memory. So if I give you a string of numbers like 5, 2, 7, 3, so you'd have to say it backwards, 3, 7, 2, 5. So that's a little bit more challenging, and that's called your active working memory. And what that does is that's our ability to, to hold information. If we're trying to make a decision about something, we'll actually have to pull in memories of that decision and compare and contrast and say, well, if I leave tomorrow for the airport at 4 o'clock and my flight's at 5, then it'll take me an hour, maybe a half hour to get there. And, I'm supposed to check in an hour early, so I better back it up to maybe leaving at 3. Okay, will I be able to take care of everything by 3 to get there? And that's your working memory. You're holding all these variables and you're thinking about them. Sustained attention is your ability to hold your attention over something that's not intrinsically rewarding. So I get it from, like with ADHD, from parents, I always have them say, well, he can play video games all day long. Well, video games, it's really great. You push a button, something happens. You push a button, something happens. Listening to me talk, you're not pushing any buttons with me, and you're maybe not getting what you want right away. So that's called sustained attention, holding your attention when something's not necessarily immediately rewarding. And that's something that we have a little bit more difficulty, especially in normal pressure hydrocephalus. So, okay, here's your memory test. Do you all remember what was up there? Just kind of think about it and see if you can count how many items, were up there in your mind. So, ready? Here we go. And some of the ways that people remember things is like they might group them together. So I didn't do, when I did this on the fly, I didn't do a really great job, but these are 2 things you can wear. These are transportation, so that might be like, okay, what were the things to wear? Okay, there was a ring and shoes. What were household items? Okay, that was, a fork and a lamp. Not sure how the brain fits in, but the brain's really cool, so I had to put that in. Things that you turn on, oh, that would be, use a key with a car. So you make associations, and that helps us be able to remember more. And that's what our frontal lobe does. That's our frontal lobe kind of comes in and helps us encode and give things meaning. Now, again, your visual memory would be, where are the things located? Okay? And that's what our visual memory is. Our verbal memory would be the names of the things. Does that make sense? So that's kind of what a neuropsych test is. So for normal pressure hydrocephalus, the areas that are most affected is the pressure tends to go outward. So the executive functioning and fine motor is impacted. And it also goes up. And right here, this light blue band, I don't know if you can see it very well, that's the corpus callosum. And the corpus callosum, what will happen is it gets really squished when the brain goes up. And that's one of the signs of hydrocephalus. And so the corpus callosum helps the right half of the brain talk to the left half of the brain and vice versa. And so when that happens, sometimes people aren't as coordinated to do things together. Because as you may know, the right hand's controlled by the left side of the brain, and the left hand's controlled by the right side of the brain. So, the corpus callosum is the one that's helping me use both hands in conjunction together and help the two sides of the brain talk to each other. So with normal pressure hydrocephalus, what we do is we have the enlarged ventricles. There's a lot of reasons this can happen. One is it could be a process that's been happening for quite some time, and it's finally become symptomatic. The other thing is sometimes traumatic car accidents can cause things to get stopped up. Any kind of brain injury, a fall. And so then we have these enlarged ventricles. And what we typically see, and my medical editor, when she was helping with this slide, she goes, oh, this is a horrible picture. It is. But one of the things you typically see is with normal pressure hydrocephalus is frequently bladder urgency. You can't make it to the bathroom. They'd usually have what we call a wide gait. So it's kind of a large kind of walking like this. And that's usually for balance because it affects balance a lot. And when they're turning, it's kind of like that. So you don't have that typical turn. So, and then of course we have the cognitive effects. So you can see these right here. These are normal ventricles. And here you can see what they look like when they're swollen. And we were talking about the corpus callosum. So this is a really great picture of a corpus callosum. Can everyone see that? It's like a ribbon right there. And you can see how it gets squished, pushed up high. And so there's a blockage right here for that one. And you can also see how this looks very large and how this is kind of pushed again up against the skull. So the great thing is that when a shunt's placed in, then the pressure goes down and the fluid drains out, and so then the front part can come back. And this happens actually really quickly. When I first started working with normal pressure hydrocephalus patients, I was amazed at how quickly people respond. So,
what does the corpus callosum do?
The corpus callosum is a band of fibers that kind of right and left, and it's kind of like this. It's like a finger, my finger's, it's a bridge between the two and shares information back and forth. The right side of the brain, it largely supports kind of grossly visual spatial information. The left side is more verbal. So we see gait appearance disturbance in up to 90%. And oftentimes with the drainage procedure, which we'll talk about in a little bit, that's the one you see respond very quickly. So it's, apraxic or magnetic gait, difficulty lifting the legs, stuck to the floor, and it oftentimes can be confused with Parkinson's or vascular disease because, there's balance difficulties, again, short stride, difficulty turning, and the rigidity. One of the things we worry about with this type of gait is they are at very high risk for falls. So one of the things I'll talk about is, do you have difficulty walking on pavement? Do you have difficulty walking on the grass? Do you have difficulty walking on sand? Usually any kind of pavement or that is uneven is very difficult for people. So again, they have the more broad-based gait, outward rotated feet with diminished heights of steps. You see that shuffling. Urinary incontinence you see in 45 to 90%. And urinary incontinence also can happen for a multitude of other reasons. With men, they might have prostate disease. With women, you know, boy, when we hit postmenopause, the bathroom is your best friend. You know, you may not complain of urgency or frequency. There also can be fecal incontinence, which is tough. So memory impairment can affect up to 80%. So again, it's a subcortical type of dementia, which means your language is intact, but you know, what we see is difficulty with slowing of verbal and motor responses. Apathy is a big one because again, it looks like depression, but it's not really depression. Forgetfulness, poor attention, but the language and the visual spatial skills are generally intact, unlike the congenital hydrocephalus that we see. And they might be very impulsive, a lot of frontal release signs. So impulsive, disinhibited, you know, very emotional, kind of like you cry at a Hallmark card kind of sort of thing. Emotional and social, we see poor initiation. So they'll be with a group of people, but they won't necessarily engage with them. They won't talk with them. They tend to be withdrawn. This is oftentimes a greater concern for men than for women because women tend to have a little bit more social skills preserved, but men frequently, because of the cognitive concerns, they don't want anyone to see them when they're struggling with names and memory, and it's like, gosh, I know who you are, but I just can't think of your name. They're slow in the process. They're having a fast conversation with somebody else, but they can't jump in because the conversation's a little too fast for them. So, and also the avoidance of activities that challenge gait, going to a picnic, going to the beach. Now, what we see with normal aging is there is, as I said, you know, there can be gait impairment, there can be urinary incontinence, and the things that we see cognitive changes is speed of processing, working memory, that ability to hold information, make decisions, attention, and learning new facts, the rate and speed of learning new facts. We can learn new facts all the way up to the end of our lives, and we retain those facts. My dad, who's 83 years old, he said he knows a lot about nothing, he says. It's like useless facts, you know, trivia. But our vocabulary continues to grow. Our knowledge and our wisdom continue to grow. We've had a lot of lifetime experiences that help us make good problem solving. So there's a lot of richness to our brain that continues to grow right up into the end. Now, with ongoing hydrocephalus, really the only cure is brain surgery. So shunt surgery or endoscopic third ventriculostomy, ETV, in basic then management of the shunt, or the symptoms. So this is a picture of spinal catheter insertion. I've watched several of these. It's amazing. At our hospital, our two neurologists who do this procedure actually are very good at it, and it's minimal pain. I've even seen people say, well, are you done yet? And they say, yeah, it's all been all finished for a minute. We've just been talking. So basically what that is, they come into the hospital on Monday, and they have a shunt placed, and they systematically drained over 4 days usually, sometimes only 3 days. And during that time, you know, they're watched for infection, that sort of thing. And then we actually do cognitive retesting at the end of the day, on Thursday, and then we also do gait measurement, so to see if their gait's improved. And usually the neurologist will come and see them every day and take them for a walk around the hallway. And believe it or not, with normal pressure hydrocephalus, we see improvement in speed of processing, we see improvement in memory and attention and fine motor skills just after 4 days of drainage. It's amazing. And that gives the neurologist information to say, you know, maybe a shunt would be a good option for you. because, your cognition improved, your gait improved. Now, sometimes what will happen is that their cognition won't improve, but their gait will improve. And then the question is to the family, is that good enough, a good enough result for you to go ahead and have the shunt, to be more mobile? And sometimes, if they're having a lot of cognitive problems, the answer may be, no, we really don't want them to be a little bit more, we don't want them to be more mobile. Maybe we'll just keep managing the symptoms and treat the headaches and all that. And sometimes it's the other way around, that the cognition improves significantly, the gait's changed only a little bit. It's usually the gait changes dramatically and the cognition is stagnant. So most cases we see improvement in both, but sometimes we don't see the improvement in cognition, it's just the gait. So what we'll do is we'll do initial neuropsych evaluation, ruling out the possibility of other dementias. And within that are embedded measures sensitive to neural pressure hydrocephalus. If they still feel like hydrocephalus is a valid concern, then we come back and we reassess with the sensitive natures. Usually tests, that's usually, I'll be honest, people are in the hospital, they're grumpy, they're tired, they're irritated, they want to get the heck out of Dodge. So that's usually only 20 minutes. We do it really quickly, in and out. And I also talk to them a lot. I say, well, how do you feel other than being really sleepy? Because the nurses wake you up all night. How do you feel like you're walking better? Do you feel like you're thinking better? And people actually usually have a pretty good assessment of themselves. It's usually, yeah, I feel like I'm a little clearer. I'm tired, but I feel like I'm remembering more stuff. And they definitely feel better about the gait. So as I said, the early diagnostic testing, we're looking for cognitive patterns that are similar, not similar to hydrocephalus. And the testing, it's briefer than 45 minutes. It's usually 20 to 30 minutes. So this is a picture of the shunt, the placement, and this is a picture of the ETV with them puncturing the hole in the bottom of the fourth ventricle. So as I said, improvement after intervention, the first thing you usually see is the gait. And when they do lumbar punctures in the office, you come in, they do the lumbar puncture and they let you go. Really, they're only assessing the gait. They're not looking at the speed of processing and memory. The third improvement that you'd see would be urinary incontinence, and the last one would be the executive and social skills. And sometimes the last two come in much later. It won't just take 4 days. So in the neuropsych report, we have the history, the test results, interpretation, and the recommendations to kind of help you out. Now, when we're thinking about normal aging, and this kind of affects how we're thinking about neural pressure hydrocephalus, is they did a nun study with these nuns. It's either in Michigan or Minnesota. I think it was Michigan, actually. That basically they followed 678 nuns. They had them write an autobiographical diary, so they didn't give them neuropsych testing, but they were basically looking at the structure of the writing and the richness of the vocabulary to get kind of an estimate of pre-morbid IQ, and also how socially active and cognitively engaged they were, and how much education they had before they went into the nunnery. And then lastly, they did brain autopsies. So the question is, they thought, well, basically if you got Alzheimer's, you would see in the brain autopsy. But what they found is that some of the nuns' brains looked horrible, but they had no cognitive symptoms. They still were highly functional, they were active, they were sharp as a tack, but their brains looked horrible. And what it is it's what we call cognitive reserve. So basically, it came out with this formula that the higher education, fewer brain insults, and good nutrition early on results in better cognitive reserve. And cognitive reserve is kind of like, the bear eating a lot of food. Oops, can you get me back on? It's the brain, eating. It's the brain having that kind of layer of fat that allows it to respond to, thank you, that kind of protects it from any neurological insult. There you go. Thank you so much. So what can we do about brain care? So the best thing is to be a good steward of your brain. And this is going to help you with your outcome with neural pressure hydrocephalus. You know, that means wear a bike helmet, minimal alcohol intake, be active, cognitively, learn new things. Like coming to this conference, you're being cognitively active. Be social. The conference, again, be interactive and have fun. And exercise. This is one of the biggest findings in the last 10 years, is that 30 minutes of daily walking can improve the size of the hippocampus. It can actually cause a part of your brain to grow by being active and exercise. Before I go into management strategies, does anyone have any questions so far? Okay, good group, quiet group. So things to kind of think about to kind of improve your memory is memory and attention. You want to keep it simple, one thing at a time, no flooding of information. Ask people to slow down. Ask people to repeat information. When you're listening to people, have really good eye contact and have minimal distractors in your environment. If you're at a party and someone's telling you detailed instructions, it's not going to be good because you'll have all sorts of distractions happening. You know, for caregivers, you know, priming rather than challenging, saying, well, don't you remember we've talked about this a million times, you know, why can't you pay attention or remember? Well, they can't remember, but if you say, well, remember when we went to the beach, you said, and oftentimes that will help them be able to make that connection and get that information. Initiation, you know, again, initiation is a big thing in hydrocephalus. So priming them, helping them get started, breaking the task down into small pieces. And frequently, patients with neural pressure hydrocephalus don't even need this after they've had the shunt input in them, because what we've seen is that we had like one CEO of a company who was totally debilitated. His kids took over his company, and then he had shunting, and he was actually able to go back and run the company again. It was amazing. So it is a reversible dementia, but these are things, you know, everyone's kind of different, so different, you know, suggestions. So breaking tasks down into small pieces, do not talk or do things for them, you know, be patient and wait and let them do it. Give space in conversations. So if you say something, because of the slow processing, it may take them a couple seconds to be able to respond to you. Not good for New Yorkers, huh? Yes, ma'am.
Is there an age that is not recommended for shunting? The reason I ask is my mom is 86 or 87, and she has dementia, and I never thought of hydrocephalus for her.
No. Well, you know, it's not really the age that would say yay or nay on shunting. What it would depend upon is basically their health to go through brain surgery. And some 88-year-olds are great, and some of them have all sorts of vascular disease and heart disease, in which case, you know, they would be high risk factors for any kind of surgery. It really depends upon the health of the individual. And plus, before they actually went to consider a shunt placement, they would look at a lot of other factors, such as, you know, does she have enlarged ventricles on MRI? Does she have the poor gait, the urinary incontinence? I'll be honest, after the age of 80, we all have a lot of vascular disease. So if you look at the ventricles, right around the ventricles, there's kind of like this white rim, and that's all vascular disease, and that's what happens to us normally. Some of it affects cognitively, others not, you know, but oftentimes vascular disease in what I call our super seniors, they oftentimes have a lot of vascular disease causing, but it's definitely worth having her be seen by a neurologist and doing the evaluation to see if there's anything they can tweak to kind of bring her better quality of life, which is what it's about, and making her feel better. You know, social avoidance, it's always good to be interactive. You know, I think the way to do it is not to do it in large groups, so for smaller groups. that are structured so that they have more chance to be able to speak and interact. And also in low stimulation settings. Again, you want to avoid, Costco or Mall of America, but stick to more smaller settings. Depression can happen in any age, and again, the best recommendation for depression is cognitive behavioral therapy and medication. Improving attention, one of the things you can do is think about feedback loops. So if you're having difficulty focusing verbally, you can kind of what we call sub-vocalize, talk to yourself when performing a task. So that kind of keeps you on track. So like if you're making chocolate chip cookies, you say to yourself, okay, now I'm getting the flour, now I'm putting the chocolate chips in, I need to break 2 eggs. And just kind of saying that to yourself kind of helps you keep mentally on track rather than kind of thinking about all these other things that might be going on. Repetition, so that when someone tells you something important, like your doctor, one couple of things you can do, you can ask the doctor if you can record them on your iPhone, so that way you can actually listen to what he says later or she says down the road. Repeating back, so what you're telling me is that I do have hydrocephalus and that we need to go off my blood thinner so that I can do the shunt procedure. And so you repeat back all the things. And then don't have them flood you with information, but give it to you in short bits and break it down. It makes it more digestible, so to speak. So improving attention, reduce interference, so that eliminate distractions, and increasing the salience of information. So you want to focus on not remembering the factual part of the information, but where it's going to get you and what's important about the information. And then, of course, improve sleep hygiene, nutrition, exercise, mood, and arousal. Again, exercise and sleep. Sleep is one of the reversible things. If someone goes on a CPAP machine, we usually see improvement in memory and attention within 3 weeks. It's amazing if they have sleep apnea. So for improving encoding, again, making sure you're paying attention, organizing, categorizing through counting items, chunking them, association. So say, oh, this is like this. And that helps you remember the situation better. And also doing visual imagery. One of the things I do is if I have to remember to bring cupcakes in the morning for lunch at work, I'll visualize myself walking out the door with cupcakes so that when I open the door, I'll go like, oh, cupcakes, because I've linked that image to the door. So verbalization, doing rhyming, cross sticks, and training domains, specific, do space retrieval, errorless learning, and vanishing cues. Those are all things that you can do to improve your encoding. Improving storage and retention, distributed practice, so you practice material briefly over an extended period of time and review it periodically, or you overlearn it, so you kind of keep going back to it, recycling it again and again. So improving retrieval, you probably noticed that, you think of a word, gosh, it's right there, I know what that actor's name is, and you start getting anxious because you want to remember it's there, you get so frustrated, and the more anxious and frustrated you get, the more I promise you will not remember it. Because sure enough, you walk away, and then within seconds you go like, oh, that's right, it was Ryan O'Neal. Excuse me. I've been talking for 3 hours now, I think. So using relaxation, deep breathing techniques. Structuring your environment and routine, so simplifying, getting rid of clutter, keeping items at the same place at the same time. When we were talking about tips for memory and executive functioning, if you have a special place for your keys, you put the keys down in that place all the time, but if you happen to come through the door, the phone's ringing, you can't do it, so you just say to yourself, I'm putting the keys on the table, and you look at the keys on the table, and then you answer the phone. And that's more likely to remember it because you looked at it, you said it, it'll help you remember it. Another thing that you can do is if you have to put something away and important, it's like a one-time thing, you can always take a picture of, I'm hiding this present from my husband and he is not supposed to find it. We've all had that. I put it in a really good place where no one will find it, and I have find it the next day. So you take a picture of it and say, okay, I hid it in the closet in the shoebox. And you take a picture of it, and it helps you remember it. So, search techniques, alphabetic searching, it really doesn't work too well. But mental kind of retracing, kind of going back over the steps helps. Queuing, first letter queuing sometimes helps. Category queuing, and that's some of the things that we actually go over. And then external aids, which, smartphones are great things, written reminders, computerized paging, appointment books, diaries and calendars. What kind of things do you folks do to help you remember and keep you organized? Lists, okay, to-do lists, great. Do you use the phone or do you write things down?
Both.
Okay, good. Anyone else? What do you do to remember things?
Make sure you write it down.
Write it down or it's gone? Okay, good. So the other thing you can do is to help your memory is if you write things down and you write down important events like you go to the doctor's, spend a couple minutes when you come home and writing what you remember about it, and then review it that evening before you go to bed, and then review it when you get up the next morning. It'll kind of lock in a lot better. And the other thing I really recommend, we're actually starting to do this at our work, is that we'll give people binder cards just like they gave you index cards, and we'll ask people to write down the 3 most important things they want from their doctor's appointment. And that way the physician will ask you for it, and they'll say, okay, these are the 3 things we're going to make sure we cover today. I have my list, but this is your list, and they make sure they cover it. But you can actually create that list and say, these are the 3 important things that I want you to talk about with me today. It's oftentimes, the doctor comes in, he's in a rush, and it's really hard to get caught up with that. So again, taking pictures of important people and places can be helpful, and reviewing that. So those are all my suggestions. Any more questions? You guys all look tired. It's a long couple of days. Yeah, I'm not taking offense at all.
What about things like hormone replacement and taking supplements that can help with memory function, those types of things?
Yeah, I've actually had a lot of questions about that today. And most of the stuff I know about supplemental, taking different things like fish oil, coconut water. It's really great ideas based on really great thoughts, but the research hasn't borne it out yet. The good news is that most of this stuff, it doesn't harm you to take. Hormones, I know a lot about hormones for women, less about hormones for men. With women, when we go into menopause, we start losing our hormones, and what will happen is for women, it's really unfair. Every time we have a pregnancy, we lose some IQ points. Bet you didn't know that. So having kids makes us stupid. And it'll come back after when our hormones are regulated, but a lot of it doesn't come back. It's a small amount, but it's definitely there. And then when you go into menopause, again, we take a hit in terms of our memory, speed of processing, and our night vision is goes down very quickly. So for women, the loss of hormones is pretty significant, and there are a lot of good hormones to take. The problem is that it also increases your risk for cancer a little bit. I take a lot of hormones because it really does help me function a little bit better. Nothing like having hot flashes when you're talking to somebody about something very serious. I was telling an elderly lady, she was so sweet, I was telling her she has Alzheimer's, which was a big diagnosis, and I felt so sad to give this to the family. Then all of a sudden I have a huge hot flash, and I go, oh my gosh. And she reaches over and she goes, are you okay, sweetie? I go like, oh, this is about you, not about me. I said, that's it, I'm going on hormones. So that, I don't know about men in terms of hormone therapy. Any other questions?
I was going to comment, Billy Graham was 82 when he had shot.
Okay.
Still going.
Very good. Again, I think it's about the health of the person for shunt surgery, not necessarily the age. Yes, ma'am.
You talked about coping skills for the executive functioning. What about when the dementia is still rearing its head, that piece, which is less likely to respond to the shot?
Right.
So what avenues can a person go to?
I think one of the things that I think the Alzheimer's Association has a wonderful website that gives all sorts of like events and how to respond to them. And you don't have to have Alzheimer's to actually benefit from the site. And I think the other thing, you know, that I've given a lot of talks over the last couple of days, and one of the things that has been a theme for caregivers is that it's very important to take care of yourself first. And because it's very hard to deal with people who have dementia because they're adults, but they often have childlike behavior and they have poor reasoning, and it's very hard to manage them. And so it's very frustrating. You love them, you have a personal relationship, and all their stuff with you comes out since you have a personal relationship. And it can be very stressful. So it's really important for you to make sure that you have a lot of patience, a lot of relaxation, stress reduction, respite. I think that for patients that do have dementia, adult daycare is really great. It's kind of like, they usually don't like to go because they like the comfort of home, but it's kind of like, let's make a deal. I'm working really hard to make sure that you have a good, safe place, but I need some me time. And my me time is when you go to adult daycare center. And when they're at adult daycare center, they're getting the cognitive interaction, which is great. They're getting the social interaction. They do a little bit of the exercise, and they also get snacks and meals and get to do some art stuff, which is just really wonderful. So, you know, I think that, again, I use the Alzheimer's Association website for like practical tips, and also I would look at really taking care of yourself. You have the strength, and that adult daycare center is a great option if you have one near you. Ma'am, you had a question?
Do you see any value in having a neuropsych test post-surgery when all things seem to be working well except cognition? And then I don't know if it's just what if we were once was, and just not being realistic, or something really is wrong.
Okay, that's a good question. So generally, we don't do retesting after the shunt surgery for 3 months because brain surgery is brain surgery, and even though the neurosurgeons don't like us to say it, it's an injury to the brain. So we need to let the brain have some chance to recover from that kind of injury with poking and prodding and, you know, the shunt placement. And then the next question, the first question would be, is your shunt working?
Well, what I don't have a shunt, I have ETV.
Okay.
And I'm 8.5 years old.
Okay, so the next question would be, is your ETV working? Because they can block up again. And if it is, then yes, I think it would be a very good time to go back and get retested and say, and especially if you got tested before, because they can kind of compare to where you were before and see where you've progressed or where you haven't progressed. You know, if there is any slippage or if you're remaining stable for your age. Because, you know, that's one of the nice things about the test is if you were like, for instance, 75 when you got tested the first time, and now you're being tested at 80, you're being compared first time to 75-year-olds, second time to 80-year-olds, so we can account for that age growth. Does that make sense? Okay. Any other questions? Yes, ma'am.
Mine's more specific. I've been interested in the Standard Learning Center for several months. I've been looking at the website, and I was just curious if their experience with dealing with somebody from across the country, like to minimize trips, like are they good at scheduling things all at once?
Yes, we are. Robin Wilson is the only neurologist that we have right now that does hydrocephalus. Our really great superstar, Dr. Williams, Mike Williams, who is the co-chairperson, he's now in Seattle. So what you might want to consider is going to Seattle to see Dr. Williams. The other person who is really super with hydrocephalus is in Baltimore. So he's at Johns Hopkins, is Mark Luciano. He's a neurosurgeon, and he is just phenomenal. I've worked with him for years. So, and Hopkins has a lot of experience with national and international travel, and so does Seattle. mean, we'd be more than happy to see you. Unfortunately, our hydro program is slightly, not as good as it used to be without Dr. Williams. And I'm always honest.
Does Dr. Luciano have somebody like you on his staff?
He does, and he should. But there are neuropsychologists that work at Hopkins. He just doesn't have anyone who works directly with him. But yeah, and Mark has worked with neuropsychologists when he was up in Cleveland Clinic. I think he's been, it's been 8 months, I want to say, that he's been at Hopkins, but it's a wonderful game for Hopkins, as he is phenomenal. He's a pediatric neurosurgeon who now does the lifespan and works a lot with normal pressure hydrocephalus. Any other questions? Yes?
My son had a ETV done in April. He was diagnosed with hydrocephalus in January. And I find this fascinating and would like to go back to our doctor, Dr. Wharf, Benjamin Wharf.
Oh, he's great. I worked with him in Kentucky.
Okay. So he's obviously familiar with this and...
Oh, yeah.
Okay.
Yeah, no, Dr. Wharf is amazing. He is such a sweetheart.
We like him.
He has a heart of gold. Oh my gosh, and he's so brilliant. He's just one of the kindest people in the world.
Thank you.
Do you handle your profession, the medications for anxiety and depression?
No,
Okay, you would have to go to a mental health.
right. What we do is we can diagnose whether you have depression or anxiety and what type. And we can make, sometimes we can make recommendations saying, probably a good medication that would be for you would be one of the medications that treats depression, but also treats anxiety. And some of them actually, the antidepressant medications can also cause anxiety. So if someone's kind of running anxious, we want to kind of make sure that they're getting, not having one of those medications. Any other questions? Well, thank you so much. You're a great way to end the day. I appreciate that. Thank you.